So now the second part of the studies, right? So post cardiac arrest. What are the relevant studies in post cardiac arrest? So very famous, the TTM trial. We were all very fascinated by this trial. That what should be the targeted temperature, and we looked at 33 versus 36, and then came one more trial. The first was the HACA trial, earlier trial where they looked at the hypothermia after cardiac arrest, so which is named as the HACA trial. Then the TTM trial, and a latest trial where they looked at the VSE, what should be the role of vasopressin, steroids, epinephrine. So the first two trials, that is the HACA and the TTM, hypothermia was instituted after ROSC, and the temperature in HACA was 32 to 34 versus normothermia, whereas in the TTM there were two temperatures, both were hypothermic, but one was 33, the other was 36. In the VSE trial, they looked at vasopressin, steroids and epinephrine, so VSE during CPR versus saline and epinephrine, and they were all multi-center RCTs. So if you look at the HACA and the TTM trial, the HACA said there was favorable outcome in patients who underwent hypothermia. Now this is a very old trial, but it did change the way post cardiac arrest patients were dealt with, and they said yes, it reduces the mortality, it improves the neurological outcome. Whereas the TTM trial said it did not make any difference whether you are keeping 33 or 36, and that's the reason now the literature says, even if you look at the guidelines, they don't say 33 degree, they say keep around 36 degree, and that's the reason the TTM changed that practice, that it does not make any difference whether your patients are at 33 or 36, and so why to keep them at 33? You can actually manage them at 36 degrees, and there was no difference in neurological outcome or mortality. This was statistically significant, but there was an issue with the trial in terms of enrollment, and the TTM was a well balanced trial, and these are the results which we follow. So HACA trial said in patients with spontaneous circulation who has been restored after cardiac arrest due to VF, if you are cooling these patients to a bladder temperature of 32 to 34 for 24 hours, there was an increased incidence of better neurological outcome, whereas the TTM said it did not provide evidence that if you are targeting a body temperature of 33 degree, it confers any benefit for unconscious patients who are admitted to hospital after out of hospital cardiac arrest, and that's the reason we do not follow a 33 degree protocol. The VSE trial said that if you are giving vasopressin, steroid and epinephrine during CPR, obviously if you are giving these, your systolic BP, mean arterial pressure, diastolic BP will be much better in the VSE group as compared to the control group. That's expected. What we were more interested in, what is the cumulative survival, and what they found was that cumulative survival post resuscitation, if there was a shock post resuscitation, the VSE group did better. So if you are administering steroids and epinephrine, but remember this is one center trial, right? So it is still not incorporated in your AHA ACLS protocol, because more work has to be done. That does it really make a difference of instituting vasopressin, steroid and epinephrine during your CPR? This was a single center trial which showed positive results here. And they said if you are giving this during CPR, the incidence of post resuscitation shock is very less. So hypothermia after ROSC should be targeted for 36 degree rather than that 33 degree. And during CPR, if you are using vasopressin, epinephrine and methylprednisolone, it offered better neurological outcome. A single center study and still not been incorporated in ACLS. So this is not to be followed as a practice changing study. TBI. Many trials are there, but the most important ones, one is the BEST TRIP trial, where they looked at what is the role of intracranial pressure monitoring. Then DECRA trial, it changed the way we look at decompressive craniectomy. Then the RESCUE ICP trial, again decompressive craniectomy. U-Therm trial, where they looked at hypothermia. So first let us look at the BEST TRIP trial, and this is randomized trial where ICP monitoring versus the clinical monitoring was considered, and the primary outcome is obviously we are looking at survival and what is the neurological outcome, and they found that it did not make any difference whether you are inserting a pressure monitoring, intracranial pressure monitoring, and then you are managing these patients, or you are managing these patients based on the clinical knowledge. It did not make any difference in terms of outcome, cumulative survival or the GCS even at 6 months. So in institution of an intracranial bolt or something was not making any difference. It was statistically non-significant. The U-Therm trial, again this was a randomized trial. ICP of more than 20 was decided to receive standard management of ICP reduction or a standard management plus hypothermia, and we looked at the Glasgow outcome scale at 6 months. What they found was there was a marginal reduction in the ICP, but hypothermia overall did not result in any improved outcomes in terms of Glasgow outcome scale. So they said now that's the reason in traumatic brain injury we do not institute hypothermia as well. Then the two important trials which looked at decompressive craniectomy, the DECRA trial and the rescue ICP trial. So both trials compared decompressive craniectomy versus the standard medical care, and the primary outcome obviously death and neurological outcome, and roughly around 500 odd patients were enrolled. Now if you look at the DECRA trial, obviously the ICP reduction will be there. You are opening up the skull, so the ICP reduction is there, that is expected. What we are looking at, what is the incidence of mortality and other things. So with DECRA trial, when you are doing decompressive craniectomy, yes, the ventilation days goes down, the ICU days goes down, that is expected. You will probably track these patients and they will move on. Similarly for rescue ICP also the similar findings were there. But when you looked at the outcome scale, what they found was that the patients were more vegetative. They were not dying. That's the whole point. By opening up the skull, they have not died, but you have made them more vegetative in nature. So patients were more vegetative in terms of if they undergo decompressive craniectomy as compared to not doing any therapy. So that was the incidence, and it did not come out to be a very good paper in terms of as a treatment for these patients, because they generally don't do well. The death was obviously lower in the surgical group because they did not die of raised intracranial pressure. You have done something for these patients. But if you look at the vegetative state, 8.5% versus 2.1%, a very high incidence of vegetative state in patients who underwent surgical interventions, and that was the conclusion of these two trials. Then hemicraniectomy in patients who had extensive middle cerebral artery stroke. Again, hemicraniectomy was taken as the intervention group, and obviously if you are doing in malignant MCS stroke or a big MCS stroke, these patients had a better survival as compared to the control group, but overall the vegetative state incidence was again higher in this group. Then CRASH 2 trial. The CRASH trial was about the steroids. Now this is about what should you do in significant hemorrhage, what is the role of tranexamic acid, and a STITCH trial where they looked at early surgery versus conservative management in patients with hemorrhage. So there were two trials which looked at traumatic brain injury, and so here they looked at CRASH trial in they talked about tranexamic acid 1 gram over 10 minutes followed by 1 gram over 8 hours as in TDS or a matching placebo, and that's the study which has incorporated this again into ATLS protocol. So this is the other thing that has come into ATLS protocol with the help of the CRASH 2 trial, that what is the effect of tranexamic acid in traumatic brain injury. And what they found was the traumatic brain injury overall the incidence was less, but the formation of hematoma was lesser in the tranexamic acid group as compared to the non. So they said that if you are doing early administration of tranexamic acid to trauma patient who are at risk of significant bleeding, it reduces the risk of death from hemorrhage with no apparent increase in fatal or non-fatal vascular occlusive. It is meant to stop the bleeding, but there was no increase in other occlusive events. So this is the reason now ATLS says if you have a significant intracranial hemorrhage, tranexamic acid 1 gram loading followed by 1 gram TDS has to be given. That's the reason this protocol has come into the picture. The STITCH trial said early surgery versus the late surgery. Again, they looked at 6-month Glasgow outcome scale, vegetative state, death and other things, and they found that there was no major difference in terms of early versus conservative, but overall cumulative survival was much higher if these patients underwent surgery. Early surgery was indicated in patients with massive intracranial hemorrhage. Then came the CRASH 3 trial where they looked at adult TBI patients within 3 hours of injury or a GCS of less than 12. Here they looked at tranexamic acid or a matching placebo. Here only a very specific patient subset was taken. In CRASH 2 there were many indications of giving tranexamic acid, and again they found that if you are giving as early as possible, tranexamic acid did better in this subgroup, and they said that evidence of tranexamic acid is safe in patients with traumatic brain injury, and if you are able to give them within 3 hours of the injury. So this was a major trial which come into the picture. So ICP monitoring hypothermia does not reduce mortality in TBI. Decompressive craniectomy, yes, it will reduce mortality, it can reduce, but it causes significant disability and vegetative states. Tranexamic acid in trauma, TBI and early surgical intervention for intracranial hematoma does reduce mortality. So that's the knowledge about traumatic brain injury. Something about nutrition. So in 2011 they looked at whether you should give early parenteral or a late parenteral, and they compared early parenteral as per European guidelines and the late parenteral as per the American and the Canadian guidelines, and they found they looked at rate of death and complication. What they found was that if you are giving late initiation, they were better in terms, and that's the reason we earlier used to follow that up to 7 days. Even if the patient is not tolerating your enteral feed, don't start your TPN and start them late, because the risk of secondary complications are higher, and that's the reason we say delay it as much as possible. But this was an old information which came into the picture, where they said whether you are only the difference was that they were discharged faster as compared to the early nutrition. Then the Eden trial came into the picture, which looked at what should be the kind of feeding that if you want to enterally feed these patients, what should be the kind of feeding? Should it be initial trophic feed or a full enteral feeding from day one? Trophic means a stepwise increase in the feeding pattern. So it was a randomized trial. Patients were either divided to receive trophic feed or full mechanical or full enteral feed. Primary outcome was ventilator free days, and what they found was it did not make any difference whether you are giving trophic feed or enteral feed. So even trophic feed is better. You can actually stepwise increase your feeding and you don't overload your patients on day one, and that's the reason we nowadays follow trophic feed in the ICU as compared to full enteral feed on day one. There were no increased incidence of mortality. Then redox trial. This was a deathbed for glutamine, right? The redox trial, here they gave both intravenous and enteral glutamine, so very high dose of glutamine. We generally don't give it in this practice, and what they found was there was an increased incidence of death in the glutamine group, and that's the reason the study was terminated prematurely, because on interim analysis only it was found that there was an increased incidence of mortality in the glutamine group, and that's the reason we most of the guidelines have taken away glutamine from the clinical course. The calories trial 2014, where they looked at what should be the route, whether the patient should be fed parenterally or enterally within 36 hours, and the outcome was mortality. So what they found was it did not make much of a difference in terms of outcome or death in ICU or hospital or any other things, and other organ free days were also similar whether these patients were fed enterally or parenterally, and they said it does not make much of a difference in terms of outcome in these patients. Then PERMIT trial. Should you underfeed your patients, or you should start standard feeding in all critically ill patients? And where they looked at underfeeding means 40 to 60% of daily calorie requirement, and what should be the outcome, and they found that it did not make any difference, and you can gradually build up your patients even if you are underfeeding these patients. For first 7 days it did not result in increase in the mortality or any other organ free days, so or any other organ failure days, and so this was statistically non-significant. So late parenteral nutrition was associated with fewer side effects and early discharge. Initial trophic feed as compared to full enteral feed does not increase ventilator free days, but still it is safer. Glutamine administration increases mortality. Route of feeding does not matter much, and you can actually underfeed your patients. Then about stroke, very important topic. The NINDS trial changed the way we give our thrombolytics. So NINDS trial looked at thrombolysis for acute ischemic stroke, and all articles of stroke are based on timelines, right? Then came the ICAS 3 trial. So NINDS trial was 0 to 3 hours, ICAS 3 to 4.5 hours, then Mr. Clean up to 6 hours, and so on. I'll go on in the other slide. So they were randomized trials. The first 2 trials looked at the effect of RTP in ischemic stroke at different timelines, and the last trial was basically an intra-arterial trial. So the dose was 0.9 mg per kg and the improvement in NIHS score was taken as the first criteria, and the NINDS trial divided these patients into 0 to 90 minutes and 91 to 180 minutes, and they found that patients did much better in terms of all neurological outcome scales if they were given thrombolytics in that time frame. Even if they are given in 0 to 90 minutes, the improvement was much higher as compared to patients who were given from 91 to 180 minutes. So it depends on the time of presentation of these patients, and they were doing much better if they were given timely, and this was statistically significant, and the survival difference was more or less the same. It did not change the survival, but it changed the neurological outcome of these patients. Then the ICAS-3, where they tried to expand the timeline from 3 hours to 4.5 hours. The dose was kept as the same dose, and again they found that the primary endpoint was better in patients who received thrombolytics. Even in that time frame, 3 to 4.5 hours, the patient's MRS score was much better, and this was statistically significant. Then came Mr. Clean trial. Now these were the patients who had an intracranial occlusion in the anterior circulation artery, and up to 6 hours. So 3 to 4.5, and now we are looking at 6 hours. So patients had intracranial, intraarterial treatment had to be possible within 6 hours of stroke onset, and the maximum dose of alteplase was divided, and again the modified Rankin score was taken as the outcome, and they found was that if you are intervening these patients within 6 hours, these patients did much better in the MRS score as compared to the other. Then came another 2 trials, the very famous, and this is very important for areas where you are looking at more of neuro intervention, the DAWN and the DIFFUSE trial. They expanded the timeline, which we were stuck at 6 hours. Now they said thrombectomy at 6 to 24 hours of stroke, and the other looked at 6 to 16 hours of stroke. So they were multi-center RCTs. They looked at thrombectomy plus your standard therapy versus the standard therapy, and the duration was 6 to 24 hours, and the primary endpoint again was modified Rankin score, and they found that if you are doing it timely within that time frame, the thrombectomy patients had a much better modified Rankin score at 90 days as compared to patients who just received the standard therapy, and both the trials concluded on the same lines. Then the extended trial, they said thrombolysis up to 9 hours. Can we do it up to 9 hours? We were up to 6 hours, 4.5. Systemic thrombolysis were up to 4.5. Now they looked at up to 9 hours. In 2019 in NEJM, this article was published. They said 4.5 to 9 hours post stroke, which was hypoperfused, but salvageable regions of brain was detected on CT and MRI. So there was a condition, you will do a SPECT scan and you will look at what is the salvageable area, and the dose was administered, and the modified Rankin score was taken, and what they found was did not make much of a difference whether you were giving alteplase or placebo, but yes, the overall the difference was better. The 0.04, if you are adjusting the effect size, the 0.04, so you have to be very sure on which subset you will be giving. It has to be a salvageable brain, otherwise the increased incidence of systemic bleeding was very high in subset which were not having a salvageable brain on CT or MRI. So all the trials had their strengths and weaknesses. So RTPA, if you are administering within 3 hours of ischemic stroke, results in better functional outcome with no increase in mortality, and now this is the guideline, right? This is the SAH guide, this is the ischemic stroke guideline. Thrombolysis within 3 to 4.5 hours also produces better neurological outcome with ICH, but the ICH does not happen much. Intraarterial thrombolysis for anterior circulation artery within 6 hours. Diffuse and DAWN said you can actually do thrombectomy within 6 to 24 hours, and 4.5 to 9 hours only if you have a salvageable brain, right? So you have to do your CT MRI accordingly, the angios, and then you can say yes, this is a salvageable brain, the penumbra is preserved, and then you can plan the thrombolysis. Ventilation, the bread and butter of critical care, right? So the ARTSNet protocol, we all know what this is. How do you ventilate these patients? So you don't ventilate at 12 ml per kg, you ventilate them at 6 ml per kg, because there was an absolute mortality reduction if you did an under ventilation. Then came 2 trials where they looked at what should be a PEEP level. So one was the LUVS trial and the other was the EXPRESS trial. They were both randomized trials, and again tidal volume was on the lower side, but they controlled their PEEP based on the PEEP plat levels, and what they found was it did not make much of a difference whether you are ventilating them in a higher PEEP or a lower PEEP, provided your plateau pressures were in control, right? Your plateau pressures should not rise whether the PEEP is high or low, and so the death in ICU, hospital, ventilation days, barotrauma, the incidence did not change much. Similar findings were there in the EXPRESS trial. Then comparison of two fluid management strategies in acute lung injury. So they said that's the reason we always say keep our ARDS patients equibalanced to negative balance by day 3, and this is from where that knowledge has come. So this is the FACT trial, right? So they looked at liberal versus conservative fluid strategy in the ARDS patients, and all the patients had either a PA catheter or a CVC in situ, and what they found was if these patients were in a liberal strategy group, as in they were conservative strategy of fluid administration, the ventilator free days were higher as compared to patients whom we gave lot of fluids, and this thing should be achieved by day 3. Then PROSEVA trial, a very important trial which changed the way you ventilate your very bad ARDS patients. The proning trial, right? 466 patients were there, and the proning duration was this is the first trial where a definitive duration of proning was mentioned. The earlier trials like the prone trial, prone supine trial, prone supine 2 trial, they did not mention a definitive duration. This is the first trial where they said 16 hours or more to be left at least. Right, so they said minimum 16 hours to see any response in any of the patient. This is the first trial where they looked at roughly more than 50% reduction in mortality from a 75% to a 38%, and this is the trial we said if you are doing prone ventilation at least for 16 hours or more, you will have a positive response provided the patient's lungs are recruitable. Then two trials about use of neuromuscular blockers. One was the Accurasis trial where they looked at what should be your neuromuscular blocker. So cisatracurium for the first 48 hours in severe ARDS, and 90-day mortality was looked at, and they found that if you're looking at death at 28 days, ICU days, hospital, yes, it was better in the patients who were receiving cisatracurium, but the duration was 48 hours and a very severe ARDS, but these patients did not have an increased incidence of ICU acquired paresis. The another trial which looked at the same question was the ROSE trial. Intention to treat analysis was there in the PF ratio of less than 150, so we are looking at a severe ARDS, and again cisatracurium was used, and primary outcome was death, and the secondary outcome was another organ failure days. It did not find the same finding. It said whether you are giving intervention or you are not giving intervention, the primary endpoint, which is hospital death, was not changed, and other endpoints were also more or less similar, and they said it is not statistically significant. The only help you get is by ventilating these patients, and whether you're giving muscle relaxant or you're not giving, it did not make any significant difference in 90-day mortality. It had its own weaknesses. It was an unblinded trial, so we don't know how true that data is, but still as a practice most of us do try to paralyze these patients if they are difficult to ventilate. Then the OSCAR and the OSCILLATE, again they took away the HF high frequency oscillator ventilator from our armamentarium. Both the trials were published in the same journal, one after the other. Randomized trial PF ratio of less than 200 was the enrollment, and the OSCAR trial said it did not make any difference in survival whether these patients are given conventional ventilation or they are given high frequency oscillatory ventilation, whereas the OSCILLATE trial said if you are giving high frequency oscillatory ventilation, you are increasing the mortality as compared to the other group, and that's the reason nowadays none of the studies recommend these kind of ventilators. Then the ART trial about recruitment. Should you recruit these patients and then titrate your PEEP? So here in experimental group, after randomization, after giving muscle relaxant, patients were recruited and then following a decremental PEEP strategy. What they found was if you are recruiting these patients, you are increasing the mortality. Right, so that's the reason after ART trial the recommendations have come, do not recruit or this, but still I don't think so anybody is following it. We still in our practice do recruit our patients off and on. So they say that if you are recruiting these patients, the increased incidence is there, and the ventilator free days are also less, and the increased incidence of pneumothorax is there if you are recruiting these patients, and that's the result that it is statistically significant. Then a prevent trial came into the picture where they looked at what should be the effect of low versus intermediate tidal volume on ventilator free days in general ICU patients who are not having ARDS. Can we ventilate them at 10 ml per kg or 12 ml per kg who are not having an ARDS? And they said low tidal volume should be 6 ml per kg and should be decreased by 1 ml per kg to 4 ml, and intermediate is 10 ml per kg with a plateau target of less than 25. And what they found, if your plateau target is under control, the low tidal volume or an intermediate tidal volume did not make any difference in ventilator free days or other mortality days. So your plateau is to be considered very important in this subset. EOLA trial about extracorporeal membrane oxygenation. So here VV ECMO versus the conventional therapy was taken into account, and it was found that the primary mortality endpoint 60 days was much lower in the ECMO group as compared to the control group, and other treatment failure groups were also lower in the ECMO group. And that's the reason we say, although it was statistically non-significant, but the incidence of improvement was there in the ECMO group, and there were strengths and weaknesses. It was an underpowered, it was a small study, and that's the reason we are not able to comment on the present role of ECMO. About ECOR, there was a supernova trial and the REST trial. REST trial is the recent one where again they looked at ARDS, PF ratio of 100 to 200 and an anticipated duration of more than 24 hours. And in supernova there were 3 different modalities of ECOR were used, and in the REST trial a double lumen catheter was inserted and a VV ECOR was initiated. Primary outcome was low tidal volume and a PCO2 of not more than 20% the baseline, and the mortality at 28 days was looked at, and what they found was they were able to reduce the tidal volume, they were able to reduce the plateau pressure, and they were also able to reduce the PCO2. If it is feasible, yes, it is helping in reducing the respiratory acidosis in moderate to severe ARDS, and similar findings were there in the REST trial, but there are no mortality differences whether you are giving ECOR or not. So if you are looking at mortality difference as the denominator, it did not make any difference, but yes, ventilation becomes easier in these patients. So ventilate with low tidal volume, higher PEEP or lower PEEP does not make any difference. Conservative fluid strategy should be followed. Prone ventilation at least more than 16 hours. Neuromuscular blockers can be given up to 48 hours. High frequency oscillatory ventilation, yes, it increases the mortality. Tracheostomy timings, I have taken away that study, that's the reason it is written here. VV ECMO for severe ARDS decreases mortality but not to statistical significance at 6 months, and ECOR is still experimental. Something about the sepsis. So one was citrus ALI, they looked at vitamin C, and this was vitamin C were given to patients 50 milligrams per kg every 6 hours for 96 hours, and the other was the placebo. These outcomes were SOFA and the other outcomes were mortality. What they found was it did not make any major difference whether you were giving vitamin C or not. Then the vitamins trial, again vitamin C, hydrocortisone and thiamine versus hydrocortisone alone did not make, again this was a randomized trial, multi-center trial, 10 ICUs were enrolled and sepsis 3 definition was taken into account to define sepsis. In the intervention group, vitamin C, hydrocortisone and thiamine was given as per the protocol. In the control group, only hydrocortisone and thiamine was allowed, only at the discretion, but no vitamin C was allowed, and we were looking at primary outcome of mortality. There was no difference whether you were giving intervention or you were not giving intervention. So again, the determining factor was vitamin C. It did not make any difference in these protocols. And they said that it did not significantly improve the duration of time alive and free of vasopressor administration. The PREVENT trial, they looked at what should be the role of pneumatic compression for venous thromboprophylaxis. This was conducted in Saudi Arabia, Canada, Australia and India. Medanta was also a center in this trial. So they looked at intermittent pneumatic compression device versus intermittent compression device along with pharmacological thromboprophylaxis, and the primary outcome was proximal lower limb DVT. And what they found, it did not result in an increased incidence if you are giving a combination of if you are not giving a combination. So whether you are giving one or two, it did not make much of a difference. And they said that there was no it does not result in significant lower incidence of proximal lower limb venous thrombosis if you are only giving mechanical thromboprophylaxis. A combination of these two does not make any sense. Thank you so much.